We're going to now move to the session on long-term care workforce. And here I'm really delighted to start with Paola Sillitti. We haven't heard yet from the OECD. We have heard how good their data is before. And Paola, I know you've been working on workforce for quite a while and in quite a lot of depth. And it's fantastic to have you here. You can start. Thank you.
Thank you so much. And I also want to echo what has been said so far. This is a great event. I'm really enjoying attending the event. Thank you for organizing it, and thank you for having me here. So I wanted to give you a bit of an overview of indeed the data we have been collecting at the OECD on the long-term care workforce, not just looking at the long-term care formal workforce, but also I will give you some data that we have on the informal carers. But of course, before starting talking about the workforce, I wanted to also show you some data on the current trends in the aging and care needs, because I think that's why we are all here. That's why this topic is raising importance in the last years. So I wanted to share you this data that we have at the OECD regarding the aging populations. At the OECD, we have some of the oldest populations in the world. The population aged 65 or older went from representing less than 9% of the overall population in 1960 to up to 18% in 2021, and this trend is ongoing. So you can see on the chart we have done some projections of how a population aging is going to increase in the coming years. And we see that in 5 countries that you can see on top of the chart, so Korea, Japan, Italy, Greece, and Portugal, the population aged 65 and older is going to represent is expected to represent 1/3 of the overall population by 2050. So, of course, this is a huge trend, and it's not expected to stop in recent years. This is also happening together with a higher prevalence of multiple chronic conditions and with the changing disease profiles. So we have seen in the past years, I won't show you the data on that here, but we have seen, and I'm sure you're all aware, an increase in Alzheimer and dementia, in the burden of Alzheimer and dementia across OECD countries. So this all leads, obviously, to increased demand for formal and informal care. And so that's how then we started collecting and working quite a lot on long-term care workforce at the OECD in the past years. And I wanted to show you here, we have done some analysis on the long-term care shortages, workforce shortages. This is not it's not news for any of us. This is a long-standing issue. We have been projecting we have been collecting data on the current share of long-term care workers in the economy. So we know that in 2021, long-term care workers made up 1.9% of total employment in OECD countries. But this also varies hugely across OECD countries. We have some data, particularly some Central Eastern European and some Southern European countries where the long-term care workforce is particularly low as a share of total workforce, while other countries like the Nordics and Japan, where they represent a higher share of the total employment. And this is related to a number of factors, including the type of care that these countries provide, the role of families and informal carers, that varies across countries, the reliance on hospital and other settings. So a number of reasons that bring us to have a huge variety across OECD countries. And here what I wanted to show you is that the OECD has done some projections on how much the long-term care workforce need to increase in the coming decade to meet the increasing care needs. And so here you can see that the share of long-term care workforce as a share of total employment will need to increase by 32% over the coming decade to meet the increasing care needs. So quite a striking result that is particularly striking when we think about the working conditions and the unattractiveness of the sector. And again, here are some key challenges that we have highlighted in the past years at the OECD. We have seen that long-term care salaries are lower compared to other sectors, even compared to the healthcare sector. Long-term care salaries are lower than the hospital sector. From what concerns the contractual characteristics, there is also a high level of uncertainty with a high rate of part-time. Part-time employment is twice the average OECD rate in the long-term care sector. And also the tenure is 2 years lower in the long-term care sector than in the overall labor market. We have countries that rely highly on migrant workers, and at the OECD we can see both sides. We see some countries where migrant workers play an important role in the long-term care sector, and on the other hand, we see countries that are struggling to retain workers in their country due to the unattractiveness and poor working condition in the sector. And finally, but not less important, there are several physical and mental health risk factors the long-term care workers are faced to, and we have 15% of long-term care workers that have reported health issues due to their job. So I wanted to show you more into detail the data we have been collecting on the workers' contractual conditions. You can see in a darker yellow the share of long-term care workers that are currently working part-time, and in a lighter yellow of long-term care workers that are in fixed-term contracts. And you can see how, on average, almost 40% of long-term care workers have a part-time contract, and more than 10% are working with a fixed-term contract. But this is really, again, we can see that there is a high variability across countries, with countries like Australia, the Netherlands, and Germany having more than 70% of long-term care workers working part-time. And then on the other hand, countries like Spain and Croatia with more than 1/3 of long-term care workers in fixed-term contracts. So really a variety, a high variety across country. And then we have also collected information on the wages of long-term care workers. And here you can see the average hourly wage of long-term care workers divided by residential care workers and home-based care workers as a share of the economy-wide average wage. So you can see that in all countries, the long-term care sector, the residential care and home-based care are below the economy-wide average wage. And this is particularly the case for home-based care. And on average, we have across 28 OECD countries, residential care workers have a wage that represents around 70% of the average economy-wide wage, and slightly lower for home-based care. So I will come back to these issues in my last session, in my last part of the presentation. But I also wanted to give you some information that we have collected on informal carers. We have heard quite a lot today about the importance of informal carers and of supporting informal carers. So I also wanted to show you some of the data that we have collected, that we have gathered at the OECD. We all know the importance of informal sector, but I think it's even more striking to see the data on paper. So here you can see the share of population that is aged 65 or older with care needs. And we can see that basically half of the people with care needs across OECD countries receive family care, so informal care. And sometimes it is almost the only type of care that people are receiving, or the biggest type of care that people are receiving. So really, I thought it's always important to look at the data and to see how important this phenomenon is. And on the other side, if we flip the coin, we see that a large portion of the population aged 50 or older is providing informal care. We have almost 15% of the population aged 50 or older, so population that is probably already having care needs or going to develop care needs, that is providing care, and 7% of this population is providing care on a daily basis. So another type of information that we have collected on informal carers is the gender perspective. We see that there is a a huge share of the informal carers that are female. It doesn't come as a surprise, but again, it's quite striking to see in the data. In some countries, this is higher than 70%, and on average, across 25 OECD countries, 60% of daily carers are female. And then we also looked at the share of informal carers who are providing care daily, on a daily basis, that is also working at the same time. We have almost 30% of informal carers that are daily carers that are also providing working while providing care. So this really highlights the importance of supporting the informal carers in their daily life, so that they are able to manage and juggle the caring responsibilities and the work responsibilities. And then I wanted to just end with some policy options. These are all policies that we have somehow seen in countries. Some of them are very well established, and some others are currently in the development phase, I would say. The first slot of policies I wanted to highlight refers to the first part of my presentation on the care needs. And it refers to slowing down the insurgence of care needs, so focusing on prevention and early diagnosis and adequate rehabilitation. And on that, I wanted to highlight that the OECD is currently doing some work on healthy aging or healthy longevity, looking at how the populations are aging, the insurgence of care needs, but also how health systems are reacting to such increase in the care needs, and also on the other side, how going beyond the health systems, how is the society overall reacting to an aging population? How can we support an aging population as a society overall? And then the second set of policies I wanted to highlight refer to improving the attractiveness of the long-term care sector. I think this has been also one of the topics of discussion today, on the importance of improving the contractual characteristics, but also having wage increases, having opportunities for career progression, and also providing training to long-term care workers. We have seen in a few countries that countries are attracting foreign workers. This is a short-term solution that a few countries, especially European countries, are putting in place. But it's also important to consider the flip of the coin again, and how this set of policies might not be sustainable in the long run. As other countries, so workforce from other countries is also aging over time. And then finally, the last set of policies focus on supporting informal carers. We have seen that there are some types of policies that are particularly developed across OECD countries. For instance, carer leave, both paid and unpaid leave, but also allowances, while other types of support like respite care and training are less developed so far. And I was very happy to see also WHO working on this topic. I think it is great and highly important. And then finally, I just wanted to, this is my last slide, I promise, I just wanted to show you the work a little bit of the work that we have been doing in the past decade. The OECD has been supporting countries on this topic of workforce challenges in the long-term care sector for over a decade now. And here are 3 of the main publications that we've been working on in the past years. Of course, you can find also much more on our website, but I will be very happy to also discuss further at the end of the session. And thank you.
Thank you so much, Paola. And I mean, we can also try and include links to the reports that you shared that are really a great reference. Thank you so much. And you are perfectly on time. And now we're going to hand over to Shereen Hussein from the London School of Hygiene and Tropical Medicine at the UK, and a long-term collaborator. And she's going to talk on an overview of long-term care workforce policy in the UK.
Yeah, thank you very much, and great to be here and listening to everybody. So I've been introduced, and I'm going to try to talk about, we've heard about the importance of the long-term care, the formal workforce to work in collaboration with the informal carer and also the individuals as part of the ecosystem. And it just really honing down on a case study of the policies in the UK and how sometimes policies can create synergies, but also tensions. So just to give people an overview, the long-term care in the UK is referred as social care. It sits in contrast to the healthcare, which is universal and provided free of charge to everybody at the point of delivery. But social care is means-tested, both needs-tested and means-tested. Although there are some little exceptions when it comes to the devolved nations. So long-term care, there are kind of devolved policy areas. So we have 4 nations: England, Wales, Scotland, and Northern Ireland. And the regulation of social care can be different across these nations. And for example, Scotland has introduced something called free personal care, which is a universal package of long-term care up to a certain threshold. We have a mixed economy of long-term care. We have now local authorities commissioning care for those who are eligible, but not usually typically providing publicly funded services. And hence the market is really important in the UK. And fees are paid to service providers, of course, affect the pay of all workers, but we see that local authorities, when they commission, they don't really interfere with what is going to happen to the money that they are paying, and they don't put specific conditions for pay and wages of care workforce. Now, just thinking about the long-term care workforce, it's quite large in the UK. It's estimated to be actually slightly larger than the health workforce. As with many OECD countries, as we've seen from Paola's presentation, the majority are women, but we have a lot of older workers. We have average age of 45 years. There are diverse occupations in the sector in terms of regulated professions, such as social workers and nurses and occupational therapists, but also a diverse group of direct care roles, whether it's care workers or support workers or personal assistants and so on. More generally, we see poor terms and conditions, not different from the OECD. We see a lot of 0-hour contracts and little statutory benefits. There is poverty within work, and there are recruitment and challenges, of course, and retention challenges, and high level of turnover and burnout. And migrant workers, as with many countries, are seen as a solution, and they form nearly 20% of the workforce. But of course, we are faced with different set of policies that related to immigration policies. Today, I want just to focus on some work we're doing in the Center for Care. So I'm leading a research group called Care Workforce Change. And in this particular presentation, I'll focus in some of the findings of one of the projects within that research group, focusing on the policy tensions, challenges, and opportunities. Just to give you an idea of the whole work we're doing in this research group, we're thinking about how workforce change happens, because obviously everyone understands the value of the workforce, and that change has to happen to make it more sustainable. But we want to understand how this kind of theorize or conceptualize at different levels. So macro level drivers, including policy reforms, but also mega trends, such as technology and climate change and regulatory changes, etc. What happens at the delivery level or the meso level drivers through innovations, care approaches, resource allocations, and what happened through the micro level, which is the kind of bottom-up approaches, the workers themselves, worker agencies, and so on. And we are trying to understand the readiness for these changes, the resistance, but also the intended and unintended consequences. And as I said, I'm going to focus on the macro level and one component of that macro level. And in this inquiry, we started by having a literature and policy review to identify the key recent policy reforms that impact workforce, and short list of these reforms, and then have consultation and co-production approach through roundtable and rapid prioritization to agree on a short list of policy reforms that are most important. And then we did foresight activities. So we have the hindsight and the foresight. And today I'm only going to speak about some of the findings from the hindsight, and specifically in two components of these policy reforms. So these are the things that have been identified. And today I'm just going to speak on personalization and professionalization. And I've heard earlier today about the importance of professionalization or regulation or training, and we see how they interact, what are the synergies between the two, and what are the tensions. So thinking about personalization, this is really a way of thinking that have been developed to think about people who are receiving care, and it's for them rather than a set of policy prescription. It's an idea around self-directed support. There are different approach, but they primarily rely on the choice and control that is linked so much to marketization, to having a market that is available for people to choose from. And it's centered in the CARE Act, which was in 2014 and have been updated in 2018. But then it have been mentioned so many times in different policy documents, such as the House of Lords Adult Social Care Committee. And what it happens, there is a mechanism to allow this happens through individualized funding, which require local authorities to give all eligible users a personal budget. And then we have the direct payment spent as a proportion of total care spent is actually less than 10% in all of the 4 nations. So it's not really a huge percentage of the spend, but it's quite an important component, but it means different things to different people. So when think about personalization, when we looked at the policy documents, we actually didn't see much conversation about the implication of personalization on the workforce. The language that we see has fundamentally changed the narrative about social care, yet its exact impact on the workforce remains complex. So we see that many frontline workers face high workload and minimal support. There is a bit of expansion of tasks linked to personalization. And this also meant that we have new emergent roles. The important role, job role that we have seen growing is the personal assistant, which have, from the statistics at the moment, have the worst pay and employment conditions, but they're often more satisfied because they kind of have a stronger interrelationship with the individuals that they are caring for. Now, the other policy trend that was important through our work and identified by the stakeholders was professionalization. Now, again, professionalization is a term that hasn't been agreed. What does it mean? People talk about it through regulation, through compulsory training, through a national induction framework, and so on. It's more recent development in terms of policy documents, and we see that it's happening really in the past few years. It's seeing it happening differently in Scotland, Wales, and Northern Ireland than in England. For example, in the 3-nation North England, we see a compulsory registration happening. When we talk to our stakeholders, it's more about public accountability rather than a tool to support the career progression of care workers. But we see the training components and certification is kind of predominant in England. With, for example, the new reforms that were introduced last year in 2023. However, with the general election that just happened in July, we have seen that the budget for these reforms, which were focused on training and standardized training and ensuring a care pathway, the budget have been axed dramatically, and it's not clear what parts of these reforms are going to take place or to continue. And in terms of professionalization impact on the workforce, it's early days to exactly understand the impact. However, from the discussions and roundtable discussions that we had, we see some unintended consequences. For example, particularly from Wales and Scotland, when training and legislation has been compulsorily with certain new certification requirement, we've seen that older workers, because we know this is an older workforce with a lot of women, maybe with certain backgrounds and less education and attainment, we see that many of them have left the work because they felt that this is not really the best time for them to set new exams and to get more qualifications. And also the way of delivering training in a fragmented system where there is no space that people actually meet or provide or have the training, and they have to do the training in their own time, and they cannot really afford to pay for the training time or miss it for work. So we have some issues and tensions here. So thinking about personalization, professionalizations, one of them, the personalization, didn't mention workers almost entirely in the document, while the professionalizations doesn't really state what would be the benefit of that. There is focus on training, on developing a career pathway with the broader aims that this will improve retention and improve recruitment, potentially to up the status of the work. In terms of synergies between these two policies, we see that stakeholders agree that the training aspect of professionalization is very relevant to personalization, because there's evidence that training around person-centered care can be really beneficial when we apply it to personalization. And there is particular focus, strong focus on care planning, and it's emphasized that the person-centered care plan is a legal document. However, it's the responsibility of the care worker to make every effort to communicate and find out what the person they are supporting wants, rather than making decisions for them. So there is some synergy between what we think is professionalization as the component of a specific training and the delivery of personalized care. But at the same time, we see some policy tensions. So for example, the compulsory registration could limit the pool of potential. We have evidence that it limits the pool of potential care worker. And also, if you have a standard set of requirement and registered staff, then it means that individuals drawing on care may not be able to select the individuals that they want to care for them more freely, because they for example, they value more the soft skills of the individual rather than the technical skills. And then after recruitment, they might be provided with training. Hence, there are kind of different needs and wants of different individuals, and there's some clashes between these two policies. So I'm nearly done, and I'm going to just speak about the key takeaways. The long-term care policies do not always explicitly discuss the role of and implications for the workforce. Although the workforce is the mechanism of delivering care, many times they are absent from the policy discussion. And it's really important to understand the context of the area that you're working with and the interactions between the long-term care policies and other policies. Because if the policies for long-term care does not necessarily have the workforce in mind, we see that there is a lot of policy conflicts and tensions, although there are synergies. There are other examples that I didn't draw on here, like commissioning and integration, for example. So we see unintended consequences and inequalities, of course, and diversity we've seen in the differentiated impact. For example, if you apply training, mandatory training for different settings, this will have implications on the groups that are attaining that training. The last message is that it's really important that we look after long-term care workers' quality of life in a dynamic policy landscape. The care workers' outcomes have to be seen and recognized as key to improving job performance and care outcome. And hence, the quality of life of care workers in its broader terms have very important implication in recruitment, retention, and the quality of care delivered. This is a dynamic policy environment, and long-term care policies are evolving and shaping the workforce in an intended and unintended ways, and they interact so much with other policies like immigration policies, like funding, like other policies. All the time they intersect. And I just want to flag out our ongoing work. So the work on the Center for Care, now we want to bring all the drivers together that I mentioned at the beginning, the macro, meso, and micro, to understand the care workforce change and to understand the tangible areas that we can work with, the low-hanging fruits. But also I want to flag another project that I'm leading, which is called Ask Will, which is developing a standardized measure of care workers' quality of life that we hope to use this tool to help us understand the impact of certain interventions. It could be support mechanisms. It doesn't have always to be wages. There are so many things that we can introduce to the workforce and test it with that one. And hence, thank you for listening. I'm sorry if I exceeded my time. I think I'm 2 minutes over, but I'll stop here and I'll stop sharing. Thank you so much.
Was an excellent overview of the policy issues and how integrated, how linked and interwoven they are. And now we're going to go to Elaine Ho. Elaine, I know it's really late in Singapore, so we really, really appreciate you staying up so late to talk to us. And we've heard a little bit about the issues relying with migration, and you're bringing us a perspective of a country where there is a very strong reliance on a migrant care workforce. So we're really looking forward to listening to you. You can share your slides when you're ready.
So thank you very much for giving me the opportunity to share about my research. So if you would like to know more about the overall project where this presentation is based, you can scan the QR code. I have also actually typed it into the chat box, if I can find it. No, I can't find it now, but later on I will add it to the chat box so that you can have a look at the Trace Project website for all the publications. Today's presentation is actually based on this project called Transnational Relations, Aging and Care Ethics, where a team of us, we got together to study intersecting care relations in Singapore as a migration hub. And of course, in Singapore, foreign domestic workers play a very important role in elder care. So today's presentation primarily focuses on this topic. And it was, the research was done together with my former postdoctoral fellow, Dr. Ting Wen Ching. So I'm going to move the focus to home-based care. When we talk about foreign domestic workers in Singapore, they are live-in caregivers, migrant caregivers who help provide either elder care work or childcare support or household support in Singaporeans' home. So in terms of elder care in particular, Singaporean families tend to prefer home-based care because they subscribe to this idea of Asian values where you have to sort of practice filial piety by showing care and concern for your elderly parents in their older age. Of course, this is changing these days, but very much so, younger Singaporeans still tend to employ foreign domestic workers to help with elder care work rather than sending their elderly parents, say, to community care. This part here, the second segment, the boxes actually refer to community care facilities, and then the last box here refers to home-based care. So what some people don't realize is in Singapore, there are actually two types of live-in caregivers, okay, or two types of caregivers who live in the home with their employers. The term that we're more familiar with is foreign domestic worker. And the foreign domestic worker is someone who can cover all sorts of roles from elder care to childcare to household housework and even pet care. Okay, but there's another category known as a live-in caregiver, and this category actually refers to a group of foreign domestic workers who are more highly skilled, more highly paid, okay, and they primarily focus on elder care only. However, most Singaporean families still tend to prefer to hire foreign domestic workers because they are seen as a type of worker who can cover all sorts of roles in the home, whereas the live-in caregiver costs more and also covers only a very narrow work scope to do with elder care. But when it comes to elderly with sort of advanced care needs, actually live-in caregivers who have a professional training are more suitable to meet those advanced care needs. So in this slide, you can see the numbers of foreign domestic workers as well as live-in caregivers employed in Singapore in recent years. And both categories, they come to Singapore under this visa, which we call the work permit. And in the next slide, you will see where the work permit fits in our visa scheme. Just to add as well, for foreign domestic workers and live-in caregivers, upon entry, when they come to Singapore, they are regulated by the Ministry of Manpower, which issues the work permits. Okay, but once they are in Singapore, the Ministry of Health runs several caregiver training programs to help train up foreign domestic workers and live-in caregivers to provide suitable care. But the challenge is Singaporean employers are not always willing or open towards enabling their foreign domestic workers to go for these training sessions because it takes them away from the work that they do. So that's why I mentioned at the last point that the gaps still remain. There's a limited take-up of caregiver training. In terms of the regulatory framework, as you can see from this pie chart, nearly 1/3 of the population in Singapore is made up of migrants. And of these migrants, 15% of them are migrant domestic workers. So as I mentioned, work passes or work permits are actually used to regulate the employment of foreigners in Singapore. Work permits in the case of the domestic workers and live-in caregivers. And depending on your different pass types, you would have different benefits. So today, I don't have the time to go into the restrictive benefits that come with or restrictions that come with the work pass, the work visa, but there have been many publications on this. So if you're interested, I can always refer you to them. So here, okay, I need to move this away so I can see. All right, so here in this table, what I've done is to try and show the difference between the foreign domestic worker and the live-in caregiver. As you can see, the live-in caregiver is paid more than the foreign domestic worker. So Singapore $800 is about £450 per month. Okay, it's not a huge amount nonetheless. Okay, but the domestic workers, they are paid even less, between about 200 to 400 pounds. So 450 Singapore dollars to 750 Singapore dollars. What's also quite well known in the academic literature is many of these migrant domestic workers, they come with debt. So in order to go and work in Singapore, they have to borrow money to pay their agents for the airfares, for the training, for accommodation. And the debt is paid off when the agent receives the salary. The agent deducts part of the salary to pay off the domestic workers' debt. Okay, and I just want to highlight as well that recently health insurance has been made mandatory for both the foreign domestic worker as well as a live-in caregiver. In the past, that wasn't the case. Okay. So for foreign domestic workers who carry out home-based care, the Singapore government has introduced several schemes and policies to make it less prohibitive for families to hire foreign domestic workers for caregiving purposes. And actually, the government provides certain subsidies, such as the concessionary levy scheme or the sponsorship scheme, to enable families with elderly family members to hire foreign domestic workers to help with elder care. Okay, and there are several other kinds of schemes in place as well that have to do with training. So for instance, the advanced placement scheme allows employment agents to bring in the domestic worker before employment is secured to help ensure that there's a better match. And they can also send the domestic workers for training in the meantime. There are also some grants to offset the costs of either sending the domestic worker for caregiving courses or to offset the cost of hiring the domestic worker. So very much, it's very much a case that foreign domestic worker employment has become part and parcel of long-term care policies in the Singaporean landscape. Now, in this slide, what I wanted to highlight, right, is that there are gender differences between domestic workers who are all female and the migrant construction workers who are males. So the construction workers are covered under the Employment Act in Singapore, but the domestic workers who are females, they are not covered by the Employment Act. And overall, the Employment Act does provide better protection. So for instance, under the Employment Act, there is a maximum number of working hours stipulated, overtime pay, notice periods, annual leave, etc. But under the Employment of Foreign Manpower Act, which applies to the foreign domestic worker, it does not stipulate a maximum number of hours that the foreign domestic worker can work. It doesn't stipulate, what the overtime pay should be. It does, however, mandate that now foreign domestic workers should be given 1 rest day per week. If the employer decides to compensate the domestic worker and the domestic worker is willing, they can forego that rest day, but there needs to be at least 1 compulsory rest day per month. So in the next 2 slides, what I want to highlight is what I want to bring across is a more humanized way of thinking about the relationship between the foreign domestic worker and their elderly employers. So as mentioned in this slide, the domestic worker substitutes the labor for family members who are working or unable to manage day-to-day care. But these domestic workers also enable older Singaporeans to engage in health and wellness activities. So here, Mr. Andy, he's wheelchair bound, and his domestic worker, Min, is from Myanmar. So she's the one who takes him out, for walks. However, there is some negotiation between the domestic worker and the employer. So for instance, on hot days, Min is actually not very willing to bring her employer out, and he has to wait until she is willing to bring him out. So in other words, what I'm trying to highlight here is that the power relations in the home is actually not as straightforward as what sometimes we may think. We often tend to think that domestic workers, are exploited, but actually when it comes to elder care, the power relations are much more nuanced. So this is another example of Madam Fazana, and she has a very positive relationship with her foreign domestic worker. So her domestic worker is from Indonesia and helps her to go to the market. The helper says that she's very close to Madam Fazana. They talk together, they provide emotional and practical support for one another. So this is what we consider in our research as multi-directional care, because there's mutual companionship happening. I think another point that I want to highlight also from our research project is when we were studying how foreign domestic workers provide care for older Singaporeans abroad, who is doing the caring for their aging family members who are left behind. So here I turn to some research that we did in Myanmar. Back in 2018, I think before COVID, we had actually done some research in Myanmar to actually understand better how foreign domestic workers, are dispatched from the home country. And we've published on this about the informal kind of work structures, training programs, etc., that they come under. I don't have the time to go into details, but if you go to our project website, the publications are there for you to refer to. But here in this slide, what I actually want to highlight is this idea of care slotting from Lena Weaver. And we found that actually in Myanmar, the carers are embedded within extended family networks and intergenerational relationships. So in Kin A's case, she's a domestic worker who goes between Myanmar and Singapore frequently because of the family's financial needs. And while she is away, her grandfather actually takes care of her 2 young children because her husband was ill. And now that her children are older, they provide him with companionship in her absence. Her grandfather brought her up as well. In another case, Nyo shared with us that, she worked for a grandmother in Singapore whom she was very close to. And before the grandmother passed away, she actually asked her son to help Nyo pay off her debt. And in return, Nyo wanted to fulfill the grandmother's dying wish. So she continued to work in Singapore for the family. But then she extends her care work also to the grandmother's brother, who lives in a different block nearby their home, as a fictive granddaughter in a care slotting relationship. And in the meantime, while she's working in Singapore, her care slot in Myanmar is actually filled by 2 sisters in her absence. So basically what we want to highlight here are the care interdependencies that tie older people or employers in Singapore with families back in Myanmar through the role of the foreign domestic worker. I want to end off by talking about elder care training. So the research that we did in Myanmar, we found that many domestic workers aspire for training, and they use this kind of stepwise training opportunities as ways of improving their salaries in a country, or to move from one country to another in order to secure better working conditions. So there are informal routes where potential domestic workers are trained by former domestic workers who have now turned into agents. But then, these kinds of informal training is really it varies a lot. The quality of the training varies a lot. The formal training routes are very expensive. And for a long time, I think until 2018, domestic worker migration in Myanmar was actually considered illegal. And so these domestic workers could not go to these kind of formal training centers to receive training. So that's why the informality was a very important kind of characteristic of domestic worker migration from Myanmar. Then over in Singapore, once they arrive in Singapore, there are informal routes where they learn how to do elder care or housework through observation or through being taught by other domestic workers or the employer's family members. But they can also go to those kind of training sessions that are offered by the Ministry of Health and its agencies or by non-governmental organizations. So to conclude, what I hope that I've been able to highlight from this presentation is the domestic workers are exposed to multiple dimensions of risk across different skills, from the home to the national skill as well as the transnational skill, spanning national spaces. And in Singapore, the government refrains from regulating domestic work in the hidden private sphere of the employer's homes. And it's because they say you cannot fully govern what happens in the private space. But undertaking domestic work at the private household level accentuates risk, and such risks are individualized. For example, debt, isolation, and the domestic workers may also internalize potentially exploitative working conditions. Their social networks and training preparation in the home country and Singapore can help mitigate some risks, but there remain structural biases in government policies and societal attitudes that the individuals themselves are unable to change. So just to end off, here I've highlighted some policy considerations, and I think for us in doing the research, we are convinced that actually caregiving training is extremely important, not only for the safety of the elderly employer, but also enable upward social mobility. But in Singapore as well, there is a need to avoid complete reliance on domestic workers for elder care because it is getting very competitive. Many of these domestic workers would rather go to Japan or Hong Kong now rather than Singapore. And also the government actually needs to enforce protection for the domestic workers. And in order for it to be effective though, both employers as well as society needs to come on board to scrutinize and expose potential exploitation. Okay, thank you very much. I will unshare now.
Thank you so much, Elaine. Such a rich presentation and so many issues to ponder. We're now going to have going to a very different part of the world. We're actually going to have our first presentation from the United States. We've got Brian McGarry, and I have a problem sometimes. I've called him Barry because of the name similarities. So Brian is from the University of Rochester, and he'll present on the workforce challenges for U.S. nursing homes. And here he's going to make the very important link between workforce conditions and quality. All yours, Brian.
Great. Thank you so much. Delighted to be here and to sort of share the U.S. perspective on what seem to be very sort of common challenges across all the different settings that have been discussed so far today. So just quickly, I think my sort of goals for this short talk are just to sort of provide you guys with a summary of some of the current challenges the long-term care workforce is facing in the U.S. with a particular focus on the nursing home workforce. And then I'm going to share some recent and ongoing work that I've been doing to sort of understand the connection between nursing home staffing and the quality of care provided in nursing homes, as well as the impact of staffing on the availability of nursing home care. And then I'll wrap up by sort of discussing some potential strategies to bolster the nursing home workforce as we look ahead. So just quickly with some background, I'll start by probably saying something everybody already knows, but we know that the COVID pandemic was devastating for nursing homes, very obviously for residents. So this is a statistic from the United States case, but the U.S. population nursing home residents are less than 0.5% of the U.S. adult population, but they accounted for more than 15% of all COVID-19 deaths. So really large and significant impacts on this population. But it's worth remembering that equally affected were the staff in nursing homes. So this is an op-ed that I published with David Grabowski and Lori Porter in July of 2020, where we looked at the mortality rates among nursing home staff during the early days of the pandemic and found, when annualized, that they were experiencing mortality rates that were much higher than the jobs that we usually think of as being very high risk, like logging, commercial fishing, roofing. So really, bolstered the idea that this was really the most dangerous job at this point in time in the country. So perhaps not surprisingly in that context, we saw a really large exodus of staff and workers from the long-term care industry, particularly in nursing homes. And I think this graph is from my colleague Bianca Fronger, and it really makes this point quite well that most of the other healthcare sector jobs and long-term care sector jobs experienced a similar dip, some more so than nursing homes at the start of the pandemic, but over time they've recovered and in fact now have staffing and labor supply levels that are above what they were pre-pandemic. That's not the case in the nursing home. We still have fewer workers in that industry today than we did in 2019. And so it's probably not surprising that we see when nursing homes are surveyed, they report pretty high rates of experiencing staffing shortages. So this data ran through the second quarter of 2023. It's broken out here by specific staff types, but if you aggregate across these, well over 20% of facilities, so more than 1 in 5 in any given week, report that they're experiencing some sort of staffing shortage. So let me pivot a little bit and tell you about some ongoing work and some published work that I've been involved in that I think sort of underscores why we should care about this, like why these persistent shortages could be very problematic. So the first work that I want to highlight here is some preliminary work. I ask you guys not to cite it, but I think in good enough shape to share with everybody today. So this work is joint with Ashwin Gandhi at UCLA and David Grabowski and LJ Rostovska. And so here what we're trying to estimate is the effect of staffing levels on the quality of care provided to residents. The way we go about doing this is we instrument for actual staffing levels using staff vacations. So we look and see, we have staffing data that allows us to see when full-time staff go on vacation of at least 7 consecutive days. And we use that to instrument for the actual staffing levels in the nursing home. This graph sort of shows the underlying relationship. The intuition here is that when a staff member goes on vacation, the nursing home can replace some, but not all of the hours of that vacationing employee. So as more staff go on vacation, the overall staffing hours per resident day, which is on the y-axis in this graph here, that slopes down as the number of staff hours on vacation go up. And so what we find is as more employees are out, we're calling them vacations, they could be absences for other reasons. But as the staffing levels drop because of these vacations, we see really clear evidence of worse outcomes for patients who are in the nursing home. So we see, this upward slope and the likelihood of being readmitted or admitted to the hospital. We see increases in patient deaths and also increases in patient falls. So I think really clear evidence that the overall staffing levels play an important role in determining how well patients are cared for in the nursing home. But it turns out it's not just the levels, it's not just having enough people in the building, it also sort of matters who's in the building and how long they've been there for. So this is a paper that was published with Karen Shen and Ashwin Gandhi in JAMA Internal Medicine last year. So in this study, we're looking at the impact of turnover, so staff sort of exiting and then being replaced with new staff on the quality of care. So there's been some work in this space before. Our real contribution here was to essentially use nursing home fixed effects to basically look within the same facility, how do their outcomes differ during periods of relatively high versus relatively low staff turnover. And we find on average about 20%, 15 to 20% of staff hours are filled in a nursing home in any given week by new employees, which suggests a really high rate of turnover. And so what we find, this is just kind of a summary of our results, focusing specifically on direct care or nursing staff turnover. So as these dots move away from this vertical dashed line to the left, we're estimating worse outcomes. And so you can see really clear evidence here again that as turnover goes up within the same nursing home, the residents of that nursing home experience worse outcomes. And these effects are particularly strong in long stay residents. So in the US, nursing homes care for both people with personal care, long-term care needs, but also sort of short-term rehab patients who are recovering from a hospital a hospitalization, but we find the effects are really concentrated in the long stayers. So in more recent work that we've been doing, really trying to understand the role of staffing in determining the actual capacity of nursing homes. And so this is really in the context of those graphs that I showed you earlier, that we have this sense that we lost a lot of staff coming out of the pandemic, and we haven't been able to replace that labor supply. So what is the implications of that for actually operating and having capacity within the nursing home sector? So again, this is joint work with Michael Barnett and Ashwin Gandhi, Andrew Wilcock, and David Grabowski. And the sort of one of the key contributions of this paper is that we come up with a measure of functional capacity, which it turns out just looking at the number of beds a nursing home has is not a great measure of their capacity, because oftentimes they may not be operating all those beds. In fact, they may not have the staffing to operate all those beds. So the bed might physically exist, but it's not actually available to be filled by a patient or a resident. So we come up with a measure that approximates that. Happy to answer any questions about that during Q&A. And then we examine how that measure of functional capacity has changed in the aftermath of the COVID-19 pandemic. At a really high level, we find really significant declines in nursing home capacity that really outpace changes in nursing home capacity that we've seen in the past. So this is nationally, across all the United States, we find about a 7 to 10% decline in 2023 relative to 2019. But you can see in these darkest blue colors here, there's some regions of the country that have lost 15% or more of their nursing home capacity, which are really significant declines. So the anecdotal reports, I've kind of alluded to this already, suggest that a lot of this capacity decline is not coming from nursing homes outright closing, but nursing homes who are still in operation having to shut down particular units or beds within their facility because they don't have enough staff to operate those beds. And when we look at this in our data, we see really strong empirical support for that hypothesis. So what we do here is we compare how much the capacity has declined in geographic regions to how much or how frequently the nursing homes in that region reported staffing shortages in some of the COVID-related data in that graph I showed a few slides back. And what we find is the regions that have the most frequent reports of staffing shortages, so upwards of 30, 40% of facility weeks or bed weeks having a shortage, we find that those are the places that have lost the most capacity, again, alluding to the idea that an inability to fill open positions means that nursing homes have to sort of shut down beds within their facility. And then we've sort of taken this a step further to say, has this had any sort of impact on patient access? So in this case, we focus specifically on patients who have been hospitalized. A good portion of those patients will typically be discharged to a nursing home, either to stay there indefinitely or to do a course of rehab before being discharged back to the community. And so for those patients who can't sort of go to an alternate setting, so for example, going home with home care, they may be at risk of having to sort of stay in the hospital and wait for a nursing home bed to open up. And here again, we see this really pretty clear, somewhat linear relationship where areas that have had the largest declines in their nursing home bed capacity, that's what we're plotting here on the x-axis, have had the largest increases in their hospital lengths of stay. So in some of these regions that have had the biggest declines, hospital length of stay is increased by 10 or 12%. And this is on top of, we've had very long trends going on back 30 years or more of declining hospital lengths of stay as hospitals rush to get patients out and sort of turn the bed over. That's what their financial incentives are. So it appears that in some ways the staffing shortages in the US are sort of reversing those trends, and patients are ending up stuck in the hospital waiting for a bed, potentially slowing their recovery and causing them to sort of languish there. So really quickly, with the time that I have left here, just to summarize, the work that I've been involved in, I think really highlights that nursing home staff are critical determinants of both the availability of nursing home care, as well as the quality of care that's provided in that nursing home. So really couldn't be more important. We see pretty clear evidence of some persistent workforce shortages. And I would say this is above and beyond what this industry has typically experienced. Of course, these are low-paying jobs, much like the other presentations we've heard today. They're tough to fill. That's always been the case, but it seems like the problem has really worsened in the aftermath of the pandemic. And this is happening at a time when, similar to other OECD countries, the population in the US is rapidly aging. Our oldest sort of baby boomers will turn 80 in 2 years, which is an age when we expect to see the demand for nursing home care spike. So it feels like we're heading towards a crisis. There are certainly some policy levers available to us to try and address this crisis. We recently, the Biden administration has finalized some federal minimum nursing home staffing rules, which is going to force nursing homes to raise their staffing levels. This will clearly increase the demand for workers, but it's not at all clear that this will increase the supply of workers, so it may actually worsen the problem. The administration has promised some additional dollars for training and incentives to bring people into the workforce, but the amount of that money is pretty small relative to the costs of hiring and retaining that staff. There's always sort of a call to invest more in the nursing home sector, which I think is well-founded. But increasingly, there's also a lot of suspicion that what we also need here is more oversight. So there's a recent paper by my colleague Ashvin Gandhi and Andrew Alensky that shows a certain amount of what's referred to as profit tunneling, where nursing homes are able to sort of take the revenues and kind of hide them in a way that kind of is good for the corporate infrastructure, but maybe not necessarily the best for residents. So there's definitely some interest in cracking down on that practice and having more oversight to make sure that the dollars that are in the system are actually going towards staffing and patient care. And then I'll also just highlight here work by myself and David and John Gruber really highlight that as immigration increases in the US, we see staffing levels in nursing homes go up and the quality of care improve. So again, underscoring something that has come across in the other two presentations, that immigration policy really is long-term care policy, so it needs to be a continued part of the discussion. And the last thing I want to highlight here is just, I think we've typically in the US undervalued long-term care workforce and long-term care labor. We tend to separate it from the medical care pieces of the US healthcare system, which we tend to value more. We did a good job of this very briefly during the pandemic, I think, of celebrating these individuals and recognizing the sacrifices they were making to work in these settings at a very dangerous time. But I unfortunately think a lot of that enthusiasm has sort of subsided and we're kind of back to status quo. So I think, you know, any discussion needs to focus on making sure that we value these workers and appreciate the really, you know, important contribution they make to caring for our older adults and the contribution they make to our society. So I will stop there and happy to turn it over.
Thank you so much. That was a very interesting reflections. And I think it also shows how interrelated all these aspects of the care system is, and how you can't talk about workforce ignoring financing. You can't talk about workforce ignoring impacts on quality of life. You have to take into account migration policies and so much more. And the next two sessions we have after this, one of them is on the future care homes, which is looking more at different models of care. And then the one after is linking very well also into quality of care. And this, it's all very much linked. So we have time for questions. I can see Kate, already one hand up. So Katie, you can go ahead.
Yeah, thank you. And thank you so much for having this panel on the long-term care workforce. I think it's really, anyway, it's just such a delight to see, because I do think it's often not talked about. I guess this is a question for Shereen. I was very much interested in, I think you're right about the tension between personalized and professionalized, but I think it has to do with a power dynamic in the caregiving relationship of who gets to set what care is in a way. And I also had a kind of a reaction to it of feeling like that's not really getting at the issue of neither is getting at the issue of what will create quality care. which has some relationship to both of those, but is actually not embedded in the policy. But the personalized is actually both might be captured by turnover, as in Brian's work, but the personalized being a relationship between the caregiver and the care recipient, where the caregiver knows, in a sense, the care recipient very well. And then the professional piece is they do need a lot of knowledge in order to handle just the kind of surprises that come up. And what I noticed in my own work with migrant care workers in the United States was that they were sharing a lot of knowledge with each other on the phone in relation to what do I do in this situation. And that is just not going to be captured by the way that people are thinking about training of care workers. And it doesn't elevate the people who do know in a way. So how do we have some of these long-term care workers become official mentors to each other? Because I think further training, as Elaine said, just makes them go into other sectors of the healthcare workforce, and in fact makes them leave the direct care workforce in a way and become nurses, or kind of. So we need to give the profession itself status in a way. Sorry, I know we're out of time too, but I was very intrigued, Paola, that why your comment as well, that migration is not our way out of this, because I think a lot of governments think it is. And so for you, it felt like I wanted more information on why you say so, and whether you feel as if governments, is it because of the closure around immigration policy in so many OECD countries, or are there other reasons why you say that? Thank you.
We're going to We're going to hear from Shereen first.
Yeah, well, thank you so much, Katy. And I think the main problem, as I see it, is the fragmentation of policy. That none of the policies want to really tackle the whole issue, and it's not a piecemeal. It's not just a training per se. It needs to be a package of this is a good job. This is an actual qualified job that we should respect, and that should also respond with the appropriate wage and appropriate working condition. And I think the issue is that because it's piecemeal, and we've seen government after government failing to look at it holistically, and the previous government promised so much around the social care workforce reforms that included components of each of these things. So it's included components of pay, components of training, of well-being. And then as we see the policy develop, it dropped some of these components, and at the end we were left with this skeleton of training and delegation of tasks that acknowledge actually a lot of the tasks that nurses usually do is going to be delegated to the care staff, but it provides with this protocol rather than what does this mean for the care worker. And then we've seen the new government, just axing the whole thing. The budget was 800 million per year, and it became 15 million. It's nothing. We were evaluating this. We've been told as researcher, sorry, you can't evaluate it because nothing is happening. And I think the fear of really tackling the issue in its totality and understanding the funding implication and thinking of long-term care as investment, and I heard that earlier on these sessions, it doesn't really pick up with the government that this is investment. You're building the workforce, and you're building the lives of the society, and it's all intersecting. The personalization component is really important because it's about kind of valuing also the soft skills. So it's not like just you have to have this. And as the Scottish stakeholders put it to us, a lot of this registration and regulation is public accountability rather than we are actually trying to build this workforce. So I think there is a narrative that has to shift, and the way that policymakers look at this, it's so fragmented. It's so, I almost feel that we need to have a new body that actually kind of connect the different policies rather than just be siloed in different things, just their power just to connect things and make sure that it's harmonized. I have to stop here. Thanks.
And Paola, do you want to come in?
Yes, thank you so much for your question. Very happy to expand a little bit on that because at the end you have that much time. But what we have seen in some OECD countries is that they are having programs, or they are making efforts to really attract workers from other countries. The reason why, and sometimes it has been successful. We have had examples in Germany where actually they have had some form of success in some way. At the same time, we have countries that are very that have different characteristics, more or less young populations, and we do hear from both ends. We also hear from countries that are losing long-term care workers because of the same type of policies. So, I mean, these countries, there are young countries where the populations are still younger, but are still facing the same challenges, and they are starting to face the same challenges. So they are worried that this is not going to work. There will be some losers and some winners. So this is one of the reasons why I was saying this might not be, it is like a short-term option that countries are using at the moment, but it might not be sustainable long-term, not for everybody, and not necessarily in a fair, equal way. Thank you for your question.
Any other questions? I also thought maybe, Elaine, you could comment a little bit on how sustainable do you think it is for Singapore to have such a strong reliance on migrant workers? And you mentioned competition from other countries. It'd be quite interesting to hear.
Yeah, so I think, maybe I can also respond to something that Katie brought up earlier. That there really needs to be an equilibrium in this triangulation of, career progression for long-term care workers who are citizens of the country, right? And then secondly, automation. Certain things can be automated to help, relieve the burden of some of these jobs. But then the third part of it is also upward social mobility for the domestic worker, right? I think, for the foreseeable future, Singapore can still rely on certain countries in the region for their supply of domestic workers. But over time, as their countries, progress economically, they may not want to come to Singapore anymore. But then that is also good for them, right? Because it means that they have options elsewhere. So I think, in the meantime, what we really need to really look out for is when these domestic workers come to Singapore, are they receiving the social protection that they deserve? Because it's just so easy for, exploitation to be swept under the carpet. I think also in response to something that Katie said, right, these migrant workers, actually, the best training that they get is from another migrant worker, because they share things, as peers. And actually, with the NGOs where we've gone to see the training, where the training is carried out, it's really quite an empowering atmosphere, because you have domestic workers who are more experienced, they know how to handle tricky situations, and they're training the younger domestic workers who then gain confidence. And it's also a space for them to socialize. So these types of NGO spaces are really critical, I think, in ensuring the social protection of the domestic workers as well.
Thank you, Elaine. And Brian, you can have the last word on the session. Any comments, any thoughts that come to mind?
Yeah, I really like this point around like the balance between personalization and professionalization. To put it in the US context, so I mentioned our sort of forthcoming minimum staffing standards. And interestingly, the way the policy was designed was to sort of incentivize nursing homes to use either registered nurses, which are like have 4 years of training, like a bachelor's degree, or certified nursing assistants, which require no sort of degree, but like a certain amount of training to be onboarded and get the certification, and really disincentivizes nursing homes from using LPNs, or licensed practical nurses, which is like a 2-year sort of associate's degree to get that training. And I've been pretty vocal about this. I think that's a really big mistake, because LPNs sort of walk that line between being professional and trained, and they have a more training than the CNAs, and they also create a very natural sort of career ladder for people who enter as CNAs. It's much more feasible for them to go back to school and get a bit of additional training to become an LPN, versus trying to do like 4 years of college with like 2 years of biology and really, basic science kind of coursework that is probably not truly essential to do the type of work that's needed in a nursing home. So I think we missed the mark there in the US, and hopefully like we sort of tweak the parameters a bit if these policies ever actually get enacted, which is a bit uncertain. But I do think that's so important to sort of have that balance between understanding the nature of long-term care is not necessarily medical care. It does require a level of professionalism, but it also needs to come with just a lot of personal care, personal touch, and sort of understanding the nuance of the job. So finding ways to reward that and incentivize that, I think, is really important. I know in the US, but it sounds like in other countries as well.
Thank you. And we don't want to contribute to the fragmentation of policy, but we actually have 3 interest groups on workforce in the Global Observatory of Long-Term Care. 2 of them are brand new, and we're announcing them today. The first one that's already done a webinar, and we'll be sharing the video soon, is focusing particularly at migration, mobility, and care workers. So it's looking at all these cross-national issues that emerge through migration and the impacts on both the countries of origin and the countries where people left, where people are going to. We have one on workforce capacity and capability, and this one will be focusing more on strategies to build up the capacity and capability. So there'll be quite a lot of emphasis on looking at ways to bring up, to train, to increase the capacity as well, both in numbers and in their confidence as well on the jobs they're doing. And then looking at recognition, we have one on working conditions and wages in long-term care. And so you can sign up for any of these groups. I've put a link to all the interest groups. You do have to be a member of the observatory in order to join these groups. And I think we'll be sharing that link as well. But now we're going to have a break because we've been going on for quite a few hours. We're going to have a 15-minute break. Then we're going to be looking at the care homes of the future with some very interesting international perspectives. So we'll be muting, closing the screens for a few minutes, and we'll see hopefully many of you soon. Bye. And thank you for an excellent session.